Hello, I am Dr. Sarah Roth. Today, I do not want to talk about a disease, but about a story. One of those stories that we live here, inside the office, and that remind us why medicine is much more than science. It is an art of listening, connecting the dots, and sometimes becoming a true detective. The story I will tell today is about a patient whom we will call Dona Helena, and her journey begins with one of the most difficult battles someone can face. Dona Helena arrived at my office referred by her oncologist, a strong lady with a serene gaze but visibly tired. She was preparing to start chemotherapy for an ovarian tumor, a diagnosis that, by itself, already shakes any structure. The next day, she was going to have a portacath implanted, a catheter that facilitates the administration of medications. Everything was being prepared for the great fight, but there was a problem. A problem that needed to be solved even before the first battle began. Dona Helena was suffering from persistent anemia. Now, what is anemia? Think of the blood as an army of microscopic delivery men, which are the red blood cells, carrying oxygen to every cell in your body. When you have anemia, the number of these delivery men decreases. The result? Unrelenting fatigue, shortness of breath, pallor, a feeling that life is in black and white. For a patient who needs all their strength for chemotherapy, anemia is a silent and powerful enemy. The first thought, of course, is that anemia was caused by the cancer itself. Tumors, especially in more advanced stages, can cause what we call anemia of chronic disease. It's as if the body, amidst inflammation and stress from the disease, simply reduces blood production. But something in Dona Helena's story told me that the case was not so simple. While I was examining her, her daughter, who was accompanying her, uttered a phrase that, without her knowing, would completely change the course of our investigation. She said, "Doctor, this weakness. My mother has always been somewhat anemic. Actually, my grandmother, her siblings, everyone in my mother's family has this anemia that never cures." At that moment, I stopped taking notes. I looked at her. That was not just a comment. It was the main piece of the puzzle. Dona Helena's story did not start with the ovarian tumor. It started much earlier, perhaps generations before. With this new information, I delved into Dona Helena's tests, and they told a fascinating and contradictory story. First, we look at the iron tests. Iron is the main component of hemoglobin, the molecule that carries oxygen. Without iron, there is no delivery. And indeed, circulating iron was low. The diagnosis seemed obvious: iron deficiency anemia or iron deficiency anemia, but then came the paradox. There was another test called ferritin. Think of ferritin as the body's iron warehouse. If iron is low in circulation, the expectation is that the warehouse is also empty, right? But Dona Helena's ferritin was high. How is this possible? Low iron in circulation, but the warehouse is full. This is where anemia of chronic disease, caused by cancer, comes into play. The inflammation generated by the tumor acts like a stubborn security guard at the warehouse door. It sees the iron inside, but refuses to release it for blood production. So, we had a dual scenario: anemia caused by cancer-related inflammation, which prevented the use of stored iron. What about the family history? That still didn't fit perfectly. Analyzing the history, we saw that her anemia was old. A test from a year earlier already showed hemoglobin at the limit. The chronic disease worsened the condition, but there was a basis, a predisposition. We went further. We analyzed kidney function. The kidneys are the command center for blood production. They produce a hormone called erythropoietin, which orders the bone marrow produce more red blood cells. Dona Helena's tests showed that her kidneys were no longer functioning perfectly, which we call chronic kidney disease, possibly linked to her hypertension and diabetes. With weakened kidneys, erythropoietin production was low. This was another factor contributing to anemia. The command to produce blood was being given in a whisper when it needed to be a shout. We were facing a perfect storm for anemia. 1. Cancer, causing inflammation and trapping iron in stores. Point 2. Chronic kidney disease, reducing the stimulus for blood production. 3. And, hovering above everything, the family history, the clue that there could be a third element, a genetic factor. With a multifactorial diagnosis in hand, we performed intravenous iron replacement, advised kidney care, and moved on to the missing piece, the family mystery. I ordered a crucial test, hemoglobin electrophoresis. This test is like a detailed analysis of the DNA of red blood cells. It allows us to identify if there is any structural alteration in hemoglobin, such as those that occur in genetic conditions. If the electrophoresis came back altered, we would have the final answer. Mrs. Helena left the office ready to begin her treatment. And we remained, awaiting the final chapter of this story. 30 days have passed. Mrs. Helena returned to the clinic and was a different person. The iron supplementation had taken effect. She was more flushed, more energetic. She had implanted the catheter, started chemotherapy, and most importantly, she felt strong enough to fight. The first goal had been achieved. But she brought with her the envelope with the follow-up tests. And there was the answer we were looking for. The hemoglobin electrophoresis had a clear result: minor thalassemia, also known as thalassemic trait. What does this mean? Let's go back to our analogy of the oxygen deliverers, the red blood cells. In minor thalassemia, the person is born with a genetic instruction to produce red blood cells that are slightly smaller and contain less hemoglobin than usual. It is a characteristic, not a serious disease. The person lives a normal life with it, usually with very mild anemia that doesn't even cause symptoms. That diagnosis was like turning on a light in a dark room. Suddenly, everything made sense. The anemia that never healed of the mother, the grandmother, the uncles, was not a mysterious disease. It was a genetic trait passed down from generation to generation. Mrs. Helena always lived at the lower end of normality. The arrival of cancer and kidney disease was what pushed this underlying condition to a level of severe and symptomatic anemia. The conversation we had that day was transformative. I explained to her, "Mrs. Helena, you do not have a disease in your blood. You have a characteristic. This is part of who you are, part of your family history. The problem is not having the thalassemic trait, but not knowing that you have it." And from there, the most important guidelines came. First guidance, for her, from today onwards, whenever you go to a doctor, the first thing you will say is, "I have a thalassemic trait." This will prevent, in the future, any doctor from seeing your mild anemia and prescribing iron unnecessarily, which could even overload your body. Second guidance, for the family, this is a hereditary trait. It is essential that your children, siblings, and nieces and nephews undergo hemoglobin electrophoresis. Not to worry, but to know themselves. So they know they can also have this trait, and so that this information is included in their medical history. It is especially important for the younger ones when planning a family, because if two people with a thalassemic trait have a child, there is a chance of having a child with major thalassemia, which is a severe form of the disease. That day, Dona Helena left the clinic not just with a diagnosis. She left with the power of knowledge. That label of chronic anemia, which for generations was seen as a sign of weakness, was redefined. Now it was an understood genetic characteristic. Dona Helena's case was a profound reminder. A reminder that our patients are complex universes. A complaint of fatigue could be the tip of an iceberg involving oncology, nephrology, hematology, and genetics. And above all, it was a reminder of the power of listening. The most important phrase of that consultation did not come from a $1 million imaging test. It came from the mouth of a worried daughter, sharing her family story. Modern medicine has incredible technologies, but none of them replace human connection. True healing often begins when we stop, look into the patient's eyes, and ask, "Tell me your story." Thank you for listening to me.